Hi, everyone. Jonathan Leipsic here. Pleasure to be moderating this exciting discussion, this case-based discussion. As many of you may know, I practice medicine in Vancouver, and I've had the privilege to explore non-invasive physiology by way of FFRCT over the last decade. And I look forward to a shared discussion this morning with dear friends, Doctors Rabbat and Barker, about some of the nuances and the learnings over the last decade, how to more thoughtfully and meaningfully integrate FFRCT into your practice, moving beyond a binary test, moving beyond just even lesion-specific physiology for that matter, but really understanding how to explore point-based, calculated, non-invasive FFRCT to inform referral to the cath lab, but as we'll also hear from Dr. Barker, to better understand how interventionalists like him are using such information to inform their revascularization. To start, I'd like to welcome Dr. Rabbat and Mark. I'd love for you to share some of your learnings really over the last 10 years. It's been a great pleasure and privilege to work with you and learn with you over the last decade, and look forward to you sharing some thoughts. So maybe we'll kick it off with you if we could. We're going to hear from you about really 10 years of FFRCT interpretation.
How good are we at identifying obstructive coronary artery disease? There's been plenty of data published over the years demonstrating the low diagnostic yield of elective angiography after traditional pathways with stress tests. 55% false positivity, leading to unnecessary testing in the cath lab. Not insignificant false negative rates, 20 to 30% of patients sent home with undetected coronary artery disease. All of these traditional stress test modalities are surrogate markers instead of direct measures of disease. So what does this data teach us? Well, for one, we're performing invasive coronary angiography in far too many patients only to tell them they don't have obstructive coronary artery disease. And two, we need a better diagnostic pathway to identify these patients upstream before sending them to the cath lab. Now, these legacy non-invasive cardiac testing modalities leave much to be desired. And this is why the American Heart Association, the American College of Cardiology chest pain guidelines has really highlighted coronary CTA as the appropriate first-line test for many patients. Now, while the current HeartFlow platform offers us a range of tools, including anatomic insights, coronary plaque quantification, as well as classification, we'll be focusing today on the FFRCT by HeartFlow analysis, as we have a decade of experience utilizing it in our clinical practice. FFRCT has an extensive foundation of clinical data, roughly 600 peer-reviewed publications, demonstrating its high diagnostic performance, reproducibility, clinical utility, which ultimately is leading to improved outcomes and economics for our patients. FFRCT is broadly reimbursed with strong clinical adoption, meaning that the integration of this technology into your practice is much easier to undertake than it's ever been. So at Loyola Medicine, we are now in our 10th year of regular clinical use for FFRCT. Now, early in my career, I was getting quite frustrated with traditional stress testing using surrogate markers of disease and believed our patients deserve better. And at Loyola University, we were a very early adopter of this pathway with FFRCT. In fact, we were the first site in Illinois to adopt the HeartFlow FFRCT analysis. And as I reflect on our clinical experience utilizing the technology over the past decade, I can say that the overall patient experience has dramatically been improved. It's very tangible when a patient can visualize their individual coronary arteries. They're much more compliant with their preventative therapeutics and adhere to their lifestyle modifications. Now, at the same time, clinical outcomes have improved with this pathway. And I've had many patients whose prior workup could not find any coronary artery disease. With FFRCT, they were appropriately diagnosed, managed, and are feeling better. A few of my patients who have benefited from this pathway with FFRCT are highlighted on this slide. In fact, Israel Sanchez was the first patient to undergo FFRCT in Illinois, and I'd like to share his story. He was referred to me by one of our primary doctors. He was a former Major League Baseball player, still continues to play professional softball, and was just inducted in the Softball Hall of Fame. And when I met him in clinic, he had said, "Doc, I can't run to third base anymore. I'm just so short of breath." Now, prior to our encounter, he had undergone multiple stress tests. And at that point, I ordered a coronary CT and FFRCT, and sure enough, he had 2 flow-limiting lesions that we went on to go and revascularize. And immediately he felt better. And he told me in follow-up, Doc, I can run all the way to home plate now without any issues. And I've had many patients similar to Israel over the years. Now, as physicians, we're much more confident in our diagnostic certainty as well. And with more widespread adoption of this pathway, the catheterization laboratory is really transforming into an interventional suite. So we're much more sophisticated in how to diagnose coronary artery disease non-invasively with this pathway. And the days of performing invasive coronary angiography for pure diagnostic purposes are going away. And the patients who are entering the catheterization lab are receiving appropriate revascularization. So the net result is a much higher diagnostic invasive coronary angiography yield and more efficient utilization of the cath lab resources. Now, because of this, we've seen a greater than 20-fold increase in our CT volumes over the years. And there have been many valuable lessons learned over the past decade, one of which is the importance of lesion-specific physiology in the diagnosis and management of our patients. So over 10 years, we've seen time and again how the addition of lesion-specific physiology to our quite robust and strong cardiac imaging program informs treatment decisions for our patients. Now, in each of these cases, you can see the crucial role of assessing the physiology throughout the entire length of the vessel to determine if a referral to cath or medical management will be most appropriate for the patient. These are 4 different patients in the representative FFR-CT analyses. So in the upper left, patient number 1, all of these pins represent FFR-CT values 1 to 2 centimeters beyond the stenosis of a diameter reduction greater than at least 30%. All of the lesion-specific FFR-CT values being negative above 0.8 in the RCA, LAD, and circumflex arteries. Now, the nadir or distal tip value in that patient is 0.7, and we'll come back to that. Patient number 2 in the upper right, you can appreciate the lesions in the distal RCA and PDA, proximal LAD, and circumflex. Again, all the lesion-specific values being negative, but the distal tip being 0.79 in the LAD. Patient number 3 in the bottom left, proximal LAD lesion with a lesion-specific FFR-CT value of 0.94. Again, the nadir value 0.76. And patient number 4 in the bottom right, intermediate lesion in the proximal LAD with a lesion-specific value that was 0.84, non-flow limiting, but the nadir value being 0.74. Now, for all of these cases, if we simply relied on the distal tip or nadir value, these patients would have undergone unnecessary invasive coronary angiography. The addition of lesion-specific physiology to cases with complex anatomic disease can be especially valuable. And we're using the information from both anatomy and lesion-specific physiology to guide appropriate revascularization decisions. So this is another one of my patients who, based off of the CT alone, was found to have multivessel coronary artery disease. And the initial recommendation based off of the anatomy was for consideration of coronary artery bypass graft surgery. Now, if we relied on the nadir values, again, you can see that the RCA is quite significant at 0.58, but in the LAD diag system, the nadir value of 0.76, and in the circumflex being 0.79. But if we focus more on the lesions, you can appreciate that there was no hemodynamically significant lesions in the LAD diag system or circ system. There's a large delta gradient across that mid-RCA lesion. So this patient was essentially downgraded from a more invasive and costly coronary artery bypass graft surgery to a single vessel PCI in the RCA. He's been doing great with that strategy. We treated the residual lesions in the LAD system, circ system, medicinally, and he's been doing fantastic at follow-up. Based on our early experience, we published the following paper to aid in the interpretation of FFR-CT. And a key finding was that a lesion-specific approach to interpretation led to a nearly 50% reduction in false positives as compared to distal tip value reporting only. And for individuals who undergo invasive coronary angiography, the rate of revascularization was much higher among those with positive FFR-CT distal to the stenosis compared to the nadir or distal tip value.
These are really fantastic cases, Mark. I would just share with you, I was reflecting on your comments. If we go back to the very first slide, highlighting all 4 of those LADs, all of which were positive in a binary sense, to your point, right? They all had values below 0.8 if you were just simply looking for a value below 0.8. But But of course, all of them had no focal lesion that had a significant translesional pressure loss or abnormal physiology distal to it. So really coming to a close with this slide, I think it really drives home the point, those lessons learned, that this is, of course, not a binary per vessel assessment. Whether or not the LAD is normal or abnormal, we know the LAD in this case is abnormal. There's a stenosis in it. The question is, will they derive an incremental benefit from mechanical intervention as it relates to angina relief and spontaneous MI? And I think you highlighted so beautifully that just going to the nadir value is really not incremental and not informative of that decision and that discussion. Really, thank you so much for those thoughtful cases. I'll pivot on to a second learning before we obviously hand it over to Dr. Barker to bring it home as it relates to really a procedural planning perspective. But, when I reflect on our decade together, Mark, I think a lot about what we were just talking about this concept that this is, of course, a lesion-specific decision, because the interventionalist, the proceduralist, she manages a lesion. She's not treating the entirety of the LAD, but rather trying to inform revascularization around the focality of the lesion identified on the CT. We're supposed to consider using this tool when we identify a stenosis in a 40 to 90 range, and of course understand whether that lesion itself, as you so thoughtfully highlighted, is causing abnormal pressure loss. And to that end, I wanted to share a few thoughts that I know we've all discussed before, but really how to manage those gray zone values. Mark, as you pointed out in one of your cases, the tool is also not binary in not only just in its location, but in the depth of the pressure loss, right? We all know that an FFRCT of 0.6 is much worse than one of 0.80, even though they're both on the positive side of a binary cut point. So to that end, we've been really exploring quite a lot around the management of gray zone values and the incremental role of translesional pressure loss. My first case is really to highlight again what Dr. Rabbat shared, that the concept that me telling Dr. Barker that the LAD is normal or abnormal, just somewhere in the LAD, not co-located with any focal lesion, is really of no clinical utility. Both of these LAD systems are abnormal in a binary sense, but the left, again, for the Dr. Rabbat's cases, of course, sees just diffuse pressure loss across the length of a dual LAD and needs medical therapy. On the other hand, the case on the right has multifocal stenosis with significant translesional pressure loss. And it's that translesional pressure loss that I'm going to explore as it relates to such a lesion, in the gray zone, 0.76, in this case, 0.75 to 0.8. Really, we know that the risk of such patients is heightened compared to those with negative lesion-specific FFRCT, but it's by no means heightened as profoundly as we see in patients with more severely abnormal physiology. So if we're really trying to inform referral to the cath lab, we really want to augment that decision. And I think, as in accordance with the CAD-RADS 2.0 document, we should augment that decision based on the location of the stenosis, but also the presence or absence of a significant delta FFRCT. Again, the visibly obvious high deltas is a very old case, one of our first cases in Vancouver on the right. Focal lesion, severely abnormal FFRCT. It's obvious that that case needs to be considered for intervention. Or again, the case on the left, despite pressure dissipation across the length of the vessel, the LAD is abnormal, but there's nothing to treat. These are obviously different cases. But let's explore what we've learned about delta FFR, and I really think it starts from the learnings from invasive physiology. We know from this invasive pullback data done with adenosine-mediated mechanized pullback of FFR assessment that there are different ways an LAD or any vessel can become abnormal. Here, Dr. Collette and his colleagues in Ulst have dropped a wire in the distal vessel, and it's being pulled back in a mechanical fashion with the infusion of adenosine. All three of these arteries drop below 0.8, very similar, Mark, to your discussion. They're all unhealthy arteries. But the case on the right, you see very slow dissipation of pressure across the entire length of the vessel. There's nothing to mechanically intervene upon. On the other hand, on the left, you see focal translesional pressure loss, where the pressure is normal and then drops like a stone across a short segment. That really lends itself to mechanical intervention. And our interventional colleagues have shown us that. There's recent data, in fact, that just came out in circulation, I believe, last week, highlighting that as sub-analysis from the PPG trial, showing that patients who have focal pressure loss, when you interrogate the physiology across a pullback, have a high probability of benefit from PCI with a low probability of residual angina, whereas patients with diffuse pressure loss have a low benefit of PCI. When we have a lesion-specific FFRCT value that's profoundly abnormal, you don't really need to calculate the delta FFR. I know if it's dropping to 0.55 distal to a focal lesion, there's got to be a profound delta, just mathematically and intuitively obvious. But if the pressure value is in the gray zone, it really becomes a more significant question. So when we see these FRCT models that drop from blue to red, blue to orange, we know by definition there's a very high delta. When we see this very slow progressive pressure loss, this is a sick LAD, but nothing focally to mechanically treat. There's no lesion-specific abnormal FFRCT, as Dr. Rabbat highlighted. When we do have, though, lesion-specific physiology that is in the gray zone, when that FFRCT value, as you see in image B, from Hide Takagi's paper in JCCT back in 2021, when you have that lesion-specific value that's in that 0.75 to 0.8 range, you really want to explore whether or not Dr. Barker is likely to drive a meaningful improvement in angina with mechanical intervention. And so to help him and help us inform the decision for referral, we want to look at the pressure value immediately before the lesion, and then, of course, the lesion-specific value distal to the stenosis, and determine the degree of translesional pressure loss to really characterize the pattern of pressure loss as was shown in those mechanized pullback analysis performed by Dr. Collette and his colleagues. In this case, you could see the delta is really quite high. 0.95 to 0.74. That means that focal lesion, while the lesion-specific physiology is gray zone or just modestly abnormal, the translesional pressure loss is profound. In an analysis of the advanced registry, we found that a delta FFR of 0.12 was significant in enriching referral to the cath lab in the gray zone. So in our practice, we've taken that number, we use a more loosely defined number of approximately 0.1 to really enrich and inform the decision around the need for referral to the cath lab when we identify lesion-specific values that are in the gray zone of physiology, 0.76 to 0.80, 0.81, as highlighted in the CADRADS 2.0 document. A couple of clinical cases. In this case, the right coronary was a total occlusion. The question was around the circumflex. Here you can see a gray zone FFRCT of 0.79. It's abnormal. It's not profoundly abnormal. Should there be consideration of intervention on the circumflex? How can we help Dr. Barker in advance of that procedure? Well, let's look at the delta in this case. We've pinned the value just above the stenosis, and we can see that the delta is really quite significant. In this case, 0.18. Despite the gray zone value, that high delta tells you that that lesion is causing a significant amount of pressure loss, and therefore intervening upon that lesion is likely to drive a meaningful benefit to this patient. Here you can appreciate the focality of the lesion invasively, correlative with the non-invasive CT and FFRCT, enriching the diagnosis in advance of the procedure by augmenting the absolute value, which was gray zone, with a delta FFR. And the last case that I wanted to share was really around a learning that we've had around ostial right coronary and left main disease. And this is an example as similar to Dr. Rabbat's comments. When you use a tool for 10 years, there are many pearls that you start to glean. And this is something that we've seen over time, that the absolute lesion-specific value is fundamentally important. Is it 0.81 or above? Is it abnormal? And then how abnormal is it? But when we see very focal lesions at the ostium of the right or in the left main, and we interrogate the pressure just distal to that lesion, it may be so proximal within the vessel, in this case, within really a centimeter of the aorta, that the absolute value may be negative as it relates to the FFRCT, in this case, 0.85. But I think exploring the delta, even when the values are negative in ostial right and in left main disease, is important because you can appreciate that the pressure is dropping across this very, very focal ostial right coronary stenosis from 1 in the aorta to 0.85 with a delta of 0.15. So when we see high deltas across the left main and across the ostium of the right, it still behooves us to really inform the decision around revascularization, exploring that delta, even when the absolute values are negative, owing to the very proximal nature of such anatomical stenoses. So I'll close there as we pivot to Dr. Barker to bring us home really about how he's using and his colleagues are using some of these data to not only plan the need for referral to the cath lab or to accept that referral, but to really plan his interventions. But I'll close with just the comment that, again, as we've learned from Dr. Rabbat, it's not about whether or not the LAD is normal or abnormal somewhere, independent of the stenosis, but rather, as he pointed out, the lesion-specific value is fundamentally important. And I think what we've learned as well is that when that lesion-specific value is in the gray zone, we really need to augment the decision with exploration of the translesional pressure loss, understanding that lesions with higher delta FFR are more likely to derive benefit from catheterization and mechanical intervention. So let me pivot to you, Dr. Barker.
Thank you so much, Jonathan and Mark. And I think this will highlight some of the points you guys were making nicely with cases that we've taken care of here in the past 6 months or so at Vanderbilt. And I think just taking a step back as the referral for these cases, there's been at least internally in our group, a huge paradigm shift where not only are we consenting people and making better informed decisions prospectively, we can even go as far as plan the procedure to allow for more efficiency, better outcomes, and safer outcomes. So we'll start with the first case. So this is a 68-year-old gentleman who was having syncopal episodes, essentially fainting and passing out, and was otherwise pretty healthy and active. And he initially underwent an exercise stress test and did very well with perfusion imaging that was normal. But he had an event monitor that showed some episodes of ventricular tachycardia that were symptomatic. And he was actually getting evaluated for a VT ablation and came to us for a second opinion. And one of the things that we've been doing routinely now in this situation where really the pretest probability is very much a gray zone here, whether or not this is ischemia, but it hasn't necessarily been ruled out yet. His EKG was essentially normal, as was his echo. And so here's the CTA we got, and clearly there's coronary artery disease anatomically with calcific plaque in the LAD circumflex. And in the right coronary, there's a focal proximal lesion that appears significant. And when it's interrogated physiologically, we see that indeed in that proximal right coronary artery, there is a focal obstruction causing physiologic consequences downstream. But to the interventionalist, the other important point here, this is not a lesion that we would jump into ad hoc. There's technically some challenges here anatomically with the tortuosity of the proximal vessel and the takeoff of the right coronary artery, that if this was simply done as an angiogram with ad hoc intervention, the success would actually probably be less than 70%. Whereas knowing this up front, we knew what kind of equipment to have prepared. And so here's the diagnostic angiogram confirming the left coronary artery has disease, but non-obstructive on the left, and then on the right, confirming the significant disease in the ostial and proximal RCA. And so with that information, we were able to pretty straightforward put in a appropriately sized stent, even with, as you can see in the middle image, small perforation that if we didn't have the right equipment to manage this would have potentially ended up with a much more challenging situation. But with the proper equipment, we were able to take care of the complication within a few minutes. And this gentleman ended up going home the next day and doing fine. So this next case, again, highlights, I think, the advantage of having this tool with CT and subsequently CT-FFR and evaluating people with somewhat of a vague pretest probability. So this is a 49-year-old woman with risk factors who had some chest pain, but really had both sort of cardiac and non-cardiac features to it. She did notice that she was getting somewhat short of breath at the exercise program that they do at her factory that she works at, but was seen by the nurse and diagnosed with basically a viral URI and was told to just take some time off. And she ended up coming to one of our outlying emergency departments. And again, her EKG is not necessarily normal, but nothing ischemic here. They did enzymes that were negative and an echo that was normal. And one thing we've operationalized, collaboration with radiology and the emergency department and cardiology, is a coronary CT for a quick turnaround time in the emergency department, usually with the idea that this is going to be normal and we can safely discharge the person from the emergency department. But as is becoming more the norm and less the exception, we're discovering more significant coronary disease on a lot of these patients. So she had some basically non-obstructive plaque in her right coronary artery. Her circumflex was unremarkable, but she did have significant plaque in her LAD and diagonal. And here we can see with the physiologic analysis, they were, again, focal lesions, as pointed out by Dr. Rabbat in Leipsic. So something that we could manage in the cath lab and revascularize. But I think more importantly here, something that's helpful is this may invasive angiographically appear somewhat more complicated, like a bifurcation lesion, but really she has two focal lesions involving the ostium of the diagonal and not the LAD in that territory, and then more distally in the LAD, a focal obstruction. And one of the tools that's becoming more available and apparent as far as helping us prepare lesions and prepare for interventions is having some sort of plaque analysis. Now, in this woman's case, it was reassuring this is soft plaque, something that wouldn't require what we are more aggressive about with plaque modification, but also illustrates that this is not a bifurcation lesion. This is something that can be treated with two independent stents that wouldn't have to be interacted and modified. So here's her invasive angio, again, showing the right coronary artery with non-obstructive disease. And then in the left coronary artery in the middle, the ostial and proximal diagonal lesion, and then the mid-LAD. And this was confirmed and sized with intravascular ultrasound. As you can see, the pre on the left and the post-intervention on the right, after what turned out to be a relatively straightforward intervention, was able to treat her and manage this, who would otherwise have been either neglected and or maybe potentially treated with something more aggressive, like a bifurcation strategy or even bypass surgery. So in summary, I think the sort of culture in the cath lab is really shifting for the better, and less one of, well, we'll wait and see what we find and then make a decision ad hoc and then go from there. We're really shifting much more to an invasive and less diagnostic procedures. And so here we summarize that we are doing a better job of confirming and treating and not really going in and just investigating and making these decisions. We can correlate not only the anatomic, but now physiologic issues and disease and discordances that occasionally come up. And we can make a better patient-centered, informed decision prior to any invasive strategy, and ultimately simplify what would otherwise be perceived as something more complicated anatomically, but when we overlay the physiology, becomes a much more simple, straightforward treatment decision.
Thank you so much for that. I thought that was a great way to bring us home and really highlighting, if I welcome back Mark, just to wrap up the discussion, the three of us here, really our exploration as imagers, understanding, again, in the early days when we got this three-vessel non-biased pressure assessment, providing FFRCT across the entire coronary tree, understanding which lesions to explore, which lesions would be more helpful to inform the decision around cath referral, understanding that the delta could augment that further. But it's really, really quite rewarding for me personally as an imager to imagine that you as an interventionalist now would be not only taking our reports, but really exploring the images yourself, understanding plaque. It was a very thoughtful comment about the morphology of the plaque, the distribution of plaque, but then also the phenotype and the depth of the pressure loss to not only decide whether or not to cath the patient, but rather how to intervene. So that was really excellent cases and very thoughtfully presented. Before we close, any last comments from you, Dr. Rabbat, or you, Dr. Barker?
Well, I think those were excellent cases. And I know that earlier we had highlighted the value of utilizing lesion-specific ischemia for multivessel disease planning. And in fact, a few days ago at Euro PCR, long-term follow-up data from FAME3 was actually presented demonstrating that among patients with triple vessel disease, FFR-guided PCI was actually more cost-effective compared to bypass surgery at 3 years follow-up. So we can use the information from the CT anatomy and now the FFR CT beyond its gatekeeping ability to the cath lab, but also to guide appropriate revascularization strategy, differentiating between bypass and PCI. And Jonathan, I'm so happy you discussed the Delta FFR CT and how it enriches the cath lab and need for referral for revasc. And there's also a lot of contemporary exciting data looking at that metric in predicting downstream acute coronary syndrome, which is quite novel. So I think there's a lot that we're learning with that metric beyond just its referral for appropriate revasc, but also at-risk lesions.
If you take a step back as a non-medical person and sort of paint the picture of when you get to the cath lab, if you're going for an invasive procedure, and would you like to have sort of the picture painted very well before you get to the procedure? Or would you take someone to the procedure and say, well, let's see what we find, and then we'll go from there? And there's a lot of risk that's involved with these decisions that are being made without your awareness. It's really obvious which way things should go. And now that the technology has really gotten so sophisticated and elegant with not only the anatomic and plaque analyses, but overlaying that with the physiologic assessment, this is really where we all want to be. And not only for those of us doing the procedures, but for the patients and the families who have to make these kind of decisions. So it's really exciting, and frankly, making the cath lab a place where people are getting, I think, better and more appropriate care.
I think there's much more to learn, but I'm really grateful to have had the opportunity to have learned with both of you over the last decade and to have shared some of our insights. And I look forward to, hopefully with good health, that we can continue to learn over the coming years how to better manage our patients and use these rich non-invasive data to inform medical management decisions and revascularization. So thank you both again, and thank you to the organizers for the opportunity to share some of our experiences.